All right. Good evening, everyone. Very excited to have you here for our talk on current concepts in the management of Little League Shoulder, the last residency hot topics of 2024. But don't worry, we have at least 12 more episodes coming in 2025, so a lot of great stuff to come. We are very excited to welcome Division One Sports Fellowship faculty members and researchers, Dr. Craig Garrison and Dr. Natalie Myers, to bring us up to speed on this important topic. Dr. Myers, the floor is yours.
Thanks so much, Ben. Happy to be here. Thanks for inviting Craig and I to speak on this topic. We do have an agenda for tonight, but before I kind of start and dive into that, I want to give a brief story on kind of how this line of work all started. It really started through physician rounding and collaboration. We collaborate with a doctor here named Dr. Conway. He's a shoulder and elbow sports med orthopedic. His main patient population is 12 to 22-year-old baseball players. And while I would round with him, he was seeing a lot of little league shoulder cases in which he seemed to have an untraditional algorithm of how he looked at this patient compared to other surgeons that I had worked with in the past. And so I started observing, I started asking questions, and really this led us down this line of research, and it started to develop over time. And really the goal for today is for Craig and I to take you through this journey on how we view and care for these young athletes. So the agenda is traditional standard of care and the diagnosis of little league shoulder. I'm going to start there. I'm going to talk about the importance of the glenoid, specifically the posterior glenoid, how we kind of quantify what we call posterior glenoid dysplasia. Craig's going to take over and talk about a comprehensive evaluation for individuals with little league shoulder, so kind of 7 considerations that you need to think about when you're in clinic, and really the management. What are some strategies that we use here to treat these individuals, hopefully giving you some algorithms and some clinical pearls that you can use in clinic, and then hopefully we'll have a little bit of time for discussion. So here's a patient case that we want to start with, and this will be presented really throughout the entirety of this presentation. The following case, so the patient is a 13-year-old right-handed pitcher, third baseman who had an onset of right shoulder pain approximately 1 year prior to initial examination by us, meaning UT Memorial Hermann Sports Medicine team. He was initially seen by a general orthopedist for right shoulder pain and was diagnosed with a growth plate fracture. He was told to take 3 months off from throwing, was given a throwing program to start after he ended that 3 months of rest. After the rest, he initiated that throwing program, was able to get back to playing third base, however, was not able to get back to pitching off of the mound. I share this particular case because it happens often in this patient population that we treat the little league shoulder, but oftentimes cannot get the player back to throw or even the position of pitching without pain, in which this was the case and he sought second opinion. And this is exactly what happens with this player and many players that we see with this specific condition, which led me down this research line. Let's talk about really traditional standard of care for little league shoulder and what that looks like. Really, back in 1966, it was described as this osteochondrosis of the proximal humeral physis. Over time, this definition grew, it developed. At one point, it was just an overuse injury to the proximal humeral physis. Then it became potentially some type of stress fracture. And even when we talk about pediatric fractures, these Slaughter-Harris type 1 fractures. In general, though, what we can kind of all agree on is the emphasis was always on the proximal physeal changes. And so when you see someone come in, especially from an orthopedic standpoint, they're going to take AP X-ray imaging almost as all standard of care. And you can see here with my mouse that yes, there is some widening to this proximal humeral physis that might be of concern, especially if we were to compare that to the non-throwing limb. When I went back and I appraised all the literature over the standard of care in terms of Little League shoulder, this is what I found, which was kind of interesting. Prior to 1998, it was really throw avoidance. Rest until symptom resolution was complete, and then actually complete facial closure of that widening of the proximal humerus. We really wanted to see that happen. From 1998 to 2010, it then became more of throw avoidance, symptom resolution, facial widening compared to the other side. So not necessarily complete closure on the throwing arm, but how did your facial changes on the proximal humerus look compared to the non-throwing arm? And then physical therapy started to come into the mix. From 2011 to really current state, it's a multimodal approach. Physical therapy, symptom progression, return to throw programming, or what we call kind of interval training programming. I found one study over the course of 20 years, really looking at return to sport or return to play in individuals with Little League shoulder. Interestingly, 95% of players returned, but a quarter of those players had a reoccurrence of pain. And they did not return until almost a 6-month marker, even people going all the way up to 8 months. Which makes you wonder, is something missing from the standard of care procedures we currently have in this patient population? And really, the humerus is only one piece of the puzzle, right? There's a whole nother bone that's involved. So what about the glenoid? We talk about the glenoid, I want to talk about posterior glenoid dysplasia. This is the rounding of the posterior glenoid rim in comparison to the normal triangular shape of the glenoid. And if I fly in here on the right side image, you can see a normal shaped glenoid in which the back of the glenoid has this pointed shape, and that's very normal on the posterior rim. But when we start to see this dysplastic change, we notice this image, and there's a sharp angular drop off on the posterior side of the glenoid, and it starts to appear to become dysplastic. Now, these changes usually occur at the same time that the proximal physis widening occurs between the ages of 8 to 16 years of age, which a lot of times these individuals are doing a lot of throwing between those age ranges. What are some of the theories out there on, well, hey, why is this posterior glenoid dysplasia even a thing? How is it developing, and why is it developing? Well, from what I could find, there's kind of 3 major things that we need to consider. One is the subcoracoid secondary ossification center located along the surface of the glenoid, which you can kind of see in this picture here. This top portion is the subcoracoid ossification center. It really doesn't fully mature until you're 8 to 10 years. So that's one thing we have going against us. The second is that the inferior 2/3 of the glenoid has been shown as really the last to ossify, and it just starts to begin to ossify at 11 to 14, and the fusion really doesn't occur between the ages of 12 to 16 years. So if we break this down, we have a combination of repetitive throwing, posterior translation forces during that throwing, a secondary ossification center that already has a late ossification age, and the demands of throwing that are leading to these maladaptive changes in the posterior rim. And this is what, in theory, is one of the reasons or several reasons that we are seeing these dysplastic changes. The question is, how do we classify this? How do we classify dysplasia when we think it's apparent? And there's been 2 classification systems in the literature thus far that I've been able to find. The first one was back in 2000. It was trimodal. And if you look at the top picture, you can see a pointed or a normal posterior glenoid. And I've highlighted that in orange for you so you can see. The next type of glenoid that you might see is this lazy J glenoid, where, excuse me, it's not quite pointed, but it's becoming rounded on the posterior rim. And then the third is the delta, the most severe angular dysplastic changes that we see to the glenoid is happening on the when we see these delta changes on the posterior rim. Now, this is a trimodal assessment, and it became really difficult for people to accurately and consistently define these on radiographic imaging over time. So another group came in and said, well, let's try to simplify this. Let's see if we can just say, hey, is the glenoid on the posterior side dysplastic or is it not dysplastic? So is it absent or is it present? And when we look at if it's absent, we're really looking at the normal triangular shape. So that picture at the very top, that pointed, or is it present? Does it have some type of lazy J or delta going on that's making it just not normal in its appearance? If we look at it from more of a bimodal approach, the reliability of that improves drastically when orthopedics are trying to identify this over time and between each other. Now, Dr. Conway, he has what he loves to have a trimodal classification system. And honestly, it's very similar to that first one that I just showed you that has the pointed, the lazy J, and the delta. He categorized them a little bit differently just in terms of how he names them. So he agrees that the pointed, lazy J, and delta all do exist, but in his mind, he categorizes them or he names them differently. So when he talks about the pointed and the normal dysplastic posterior rim of the glenoid, he calls that beveled. When he talks about a lazy J pattern, that's more rounded or blunted. And then delta is that sharp angular displacement of the posterior rim of the glenoid. Well, you might be wondering, how is this dysplasia actually captured? And I think you've probably come to the conclusion at this point that the best way to capture this is through radiographic imaging. There's a lot of different patient positionings that you can use to see the posterior glenoid rim. We use the modified axillary view, or what we've coined to be the Conway method. Basically, the person is sitting upright with the shoulder and abduction, and the X-ray beam is shining right down on top of their shoulder. The criteria, though, for the X-ray, you really have to see two parts of this to get a really good image, to truly get a grasp of how much dysplasia they actually have. The first one is in figure A here. You have to see the suprascapular loop where the spine of the scapula meets the glenoid neck. And you can see that picture in A where it's highlighted in yellow. If you can see that loop and your image is parallel to the face of the glenoid, so meaning there's not any rotation of the glenoid face going posteriorly, and there's not any rotation going anteriorly. It needs to be straight on so you can get a true appreciation for what does that posterior glenoid look like. Here you can see these two criteria are being met. We can see the loop in the imaging, and it's parallel to the face of the glenoid. And those two things make a good X-ray when you're trying to see if someone has dysplasia. If we get the correct image and can see the posterior rim, the question is, can the dysplasia really start to remodel itself? And we find that in the cases that we've seen that it actually can. There's a really good chance of this starting to ossify in. Conway believes that you have a much better chance of remodeling that posterior glenoid that you see here if the coracoid apophysis is open. So I'm going to kind of draw arrows, and you can see that coracoid apophysis is still open in this individual. And so in his mind, this is almost a trigger saying, okay, we have a plan if it is open that this posterior rim can actually start to ossify in. So on the left-hand side, this is an example, again, the case of a right-handed pitcher. So his left is his non-throwing arm, and what do you see? You see a normal pointed posterior rim. Well, what do you see on the throwing side? You see more of this angular or delta slope that's occurring at the posterior rim on the throwing arm. Now, the interesting thing, at 8 months, when this individual comes back for serial x-ray, you can see he no longer has a delta dysplasia going on. He almost has a lazy J. It started to ossify in. It's never necessarily going to go straight back to being pointed, but at least you have bone ossification on that posterior rim to help stabilize the joint in general. So in general, delayed posterior glenoid ossification may significantly prove if no throwing is allowed and all other kind of posterior compression load forces activities are limited for this 6 to 12 months. You're going to start to see ossification, and specifically if that coracoid apophysitis is still open. I want to share some preliminary data of these baseball players that we have come into our clinic with Little League shoulder. I did a little case on 23 baseball players diagnosed with Little League shoulder. 90% of the players had evidence of posterior glenoid dysplasia. Excuse me. Of those, average bone loss was 18 plus or minus 7% when compared to the non-throwing side. So an example of that, this is a non-throwing side. You can see the pointed posterior rim. But if we compare that to the throwing side, well, what do you see? You should see some type of delta or angular dysplasia occurring. So there's been bone loss in this individual. And on average, looking at the 23 players, it was about 18%. Now, we were able to do serial imaging on some of these. 10 of the 23 players had serial imaging, and all players demonstrated evidence of posterior glenoid ossification at either 3 and 6 months when compared to that initial visit screen. So we have the initial visit right here, and you can see that it's hard to see the green line, but what we're doing is measuring the width from the anterior rim all the way to when the dysplastic glenoid starts to happen, and we get the articulation of that width in millimeters. And so you can see very clearly at baseline or at initial visit, there was some type of delta dysplasia going on. And then when that individual came back at 3 months in this case, you can see that there's been ossification that has been occurring on this individual. And so the line has now gotten longer, and it's not necessarily a delta anymore. It's starting to ossify in, which is a good news. Well, what are the consequences of this dysplasia? What's the impact of posterior glenoid dysplasia if it goes untreated? Well, there's not a ton of literature on long-term health and long-term outcomes, especially in Little League shoulder. There's no research on that, honestly. But when you go back and you look in terms of the general population, it has been associated with posterior and multidirectional instability. When we talk about just in general overhead athletes, may be symptomatic with an increase in throwing, which we have seen in clinic from just clinical sight and having seen these individuals a lot come through the office. Baseball in particular, you potentially could suffer from what's known as dynamic posterior instability of the thrower, which is pain during follow-through phase due to posterior labral chondral pathology on the back of the shoulder that you can potentially get. I think Craig is going to take over here and start to talk about comprehensive evaluation of the youth throwing with shoulder pain. Craig,
Thanks, Natalie.
Are you good? Yeah.
Yep. Yeah, perfect. Okay, good. Yeah, thank you. So Natalie set us up very nicely to kind of explain what it is we've been seeing over these past several years as we look at the Little League shoulder. So obviously a little different take than what you would typically see in the traditional evaluation of this. When we look at things, we have things that we think that are really important. One of the things I want to clarify, though, is as we talk about this, we are not necessarily changing what is happening. So our interventions or treatment strategies aren't necessarily changing what is going on at the bone. What it is doing is addressing some of these other modifiable risk factors that are occurring and showing up at the same time as we see this. So when we look at this, when we look at these Little League throwers, and our throwers in general, these are some of the things that we think are really important. So these individuals come in with some type of scapular dyskinesis. When we say weakness, it's really an inability to be able to control that scapula in a throwing motion. They obviously have shoulder pain. When you look at it, the question is always, is it coming from the humeral physis and the widening? Not necessarily. Sometimes it's just coming from within inside the joint, whether it be bursal related, different types of things like that, including some type of neural pathology that we'll talk about. One of the big things that we see, though, in these individuals is the shoulder motion loss, and it's really external rotation loss in the context of humeral retrotorsion. We'll talk more about that. And then we see a generalized overall shoulder weakness, really an abduction, scapula, and an external rotation. As we start to tie our treatment together, that'll make a little bit more sense. Clearly, they have this proximal and humeral physial stress reaction that takes place, that widening that occurs. And traditionally, that's what most sports medicine docs and even physical therapists are looking at, is saying, oh, you've got some humeral widening there, some physial widening, and so we just need to kind of shut you down. The big thing for us, though, is that in relationship with that widening, you see this glenoid, posterior glenoid delayed ossification. So Natalie brought up a really good point on the very last slide when she was talking about the fact that these, if it's not addressed, then what will happen is that when they're older, they continue to throw, they may develop other compensatory patterns, especially this new diagnosis called dynamic posterior instability in the thrower, where you start to see, kind of like Natalie was describing, as they start to get to the release point, they'll lose their ability to kind of control the humeral head as they start to go into a high velocity internal rotation adduction, and they'll sometimes actually start to slip out the back if they have posterior glenoid dysplasia. So another topic for another time, but something to consider if this is not addressed early. And then one of the big things we see is this upregulated neural pathway. So we see this increase in neural tension and what we call symptomatic TOC, or thoracic outlet compression. So it's not a full-blown thoracic outlet syndrome, but it's bordering on that, where we're getting compression. Slide, please. Perfect. So when we look at this from a comprehensive evaluation, we have a baseball medicine team that we've kind of come up with a philosophy. How do we treat baseball players? And these are some very specific things that we think are really important. So we look at sport-specific adaptations. We think that when we're looking at shoulder range of motion, we need to look within the context of humeral retrotorsion using dynamic or ultrasound to actually see what is going on in the osseous changes. We think that rotator cuff tears can sometimes be adaptive. Now, in this population, we're not necessarily talking about rotator cuff tears, so that may not necessarily apply here. Most of these throwers, especially the Little League, they do have these extreme ranges of motion, and so we need to figure out how to control some of that motion. Most of these individuals don't need a lot of stretching. What they need is some stability and a down regulation of their nervous system. We think the full kinetic chain activity, if we truly think that baseball is that, we need to really address it as such. And so we think it's very important to look at our stance and lead limbs and the actions that they have to take place, and looking at some of these correctable kinetic chain issues that we can probably take care of. We look at this, that kind of falls into our treatment categories, where Conway and our team will obviously say, we really need to see them fail conservative care before they're going to go to surgery. So we think that our treatment should really match what our assessment is looking like. The other piece of this is we see this a lot with our throwers. We see high volume training with the rotator cuff. And what we try and remind our individuals and our baseball medicine team is that when you're taking care of these individuals, you've got to remember that rotator cuff has very small cross-sectional area. So we don't need a lot of high force. What we need is a lot of good activation that actually helps to position that humeral head within the glenoid. And then from my buddy Chuck Thigpen, that always talks about this, it's basically the fundamentals. Just get back to blocking and tackling, the simple things of restoring range, decreasing the upregulated nervous system, taking care of the activation of the muscles, and then working to make sure that we're addressing the kinetic chain issues. Now, one of the big pieces that when we talk about this is the sequencing piece. We think that's very important, and I'll go into that in the next few slides, but we feel like we need to sequence our treatment to make sure that we're addressing these issues in a formal manner. We think that throwing and hitting, we think that's really important. We need to mechanics and making sure we're understanding that. And then again, like we talked about from the nervous system, looking to downregulate that if it's necessary. So when we look at management of Little League shoulder, what is it that we do? So we bring our patient case back into it. Remember, the 13-year-old, again, had been treated, I don't want to say misdiagnosed, maybe underdiagnosed. So they come to see us for a second opinion. They come back and they're looking at what is actually going on. So if we go through and we look at what the imaging was again. So on the right side, what you can see is that humeral physeal widening compared to the left side, right? And so again, that's the traditional care that most orthopods are going to do. They're going to say, oh, you've got some physeal widening. We need to we just need to shut you down. You can't throw. We don't want you just to rest. So there is a piece of that, but the missing piece from our standpoint is they need to be doing active rest. They need to be involved in this physical therapy and addressing some of these correctable kinetic chain issues. Again, on the left-hand side, what you see, the right side, what you'll see is this posterior glenoid dysplasia where there's a loss of ossification compared to the non-throwing side where you see that straight across. So you see a nice level pointed glenoid on the posterior portion. So again, when we're addressing this, we're not necessarily saying, oh, we're going to go back in and our treatments are actually going to address this and affect it. But I do think we can make an argument to say we're going to apply forces across the shoulder and elbow that allow it to start to kind of heal and allow for that healing to take place within the posterior glenoid. Slide. So here's our diagnosis from that 13-year-old. All right, so we start off and we say there's a series of diagnoses that are what we would call clinical diagnoses, which Conway loves, and then there's medical diagnoses. So you say, okay, we've got this postural issue, we've got this loss of range of motion, we have this increased median nerve neural tension, which when you look at this diagnosis, and this is the diagnosis coming from our orthopedic surgeon. So when you look at this, as a PT that's working with him, you're excited to see that he's actually looking at considering these things. We always joke around and say he's definitely drank the Kool-Aid with what we've been talking about for so many years, right? So you look at this and you see, well, he's got all these clinical diagnoses with the neural tension, with the loss of external rotation in the shoulder based on humeral retrotorsion measurements, and weakness in scaption and external rotation. And then our overall medical diagnosis, what you see is moderate to severe posterior glenoid dysplasia with incomplete posterior glenoid ossification, meaning what we've been showing you from those x-rays. So what do we do? So we look at this from a patient case standpoint. There's certainly an education piece to this, but there's also a change or an implemental change piece that we can make. So if you look at the specialization or the education piece, we're certainly talking about sport specialization, throwing for multiple teams, arm fatigue, pitch volume, selection, throwing velocity. All those things are really important and definitely go into our treatment. But where we can really make this change are these correctable, modifiable kinetic chain issues. So rotational motion, shoulder strength. We think if this is a kinetic chain issue, we need to look at stance and lead limb balance and power and ability to actually transfer force, and then looking at shoulder range of motion within the context of humeral retrotorsion. So here's our baseline data for our 13-year-old. So what you'll start to see is, Natalie, if you can hit the slide, what we'll see is that there's some loss of external rotation on the throwing side versus the non-throwing side. Now, this is placed within the context of humeral retrotorsion. So we're using ultrasound to actually look at the osseous changes that take place. Like I said, that's a whole other talk for another time. But we feel like that's very important to understand what the osseous changes have taken place, throwing side versus non-throwing side, that start and begin at a young age. Now, one of the interesting things that we'll talk about with this, when we look at humeral retrotorsion, you think about the mechanism as they go into external rotation, there's a certain amount of stresses that come across the physis of the humerus, but some of those same stresses that go into external rotation come back onto the posterior portion of the glenoid. So they definitely go hand in hand. And you'll see some humeral or some glenoid retroversion sometimes as well. In this case, though, what we're looking at for what we can address is they've lost external rotation of about 15 degrees. In addition, if you look at their glenohumeral abduction, they're missing about 10 degrees of abduction, which is very important. As they start to throw, if they cannot get into abduction, they can't get their full external rotation. Now, the other piece of this we talked about was the strength issue. And look at the throwing side, which is the right, versus the left, and the loss of strength, anywhere from 9 to 13 pounds of loss of strength. And those are pretty low numbers when we look at this. So these individuals, we're not saying that that's what caused it, but as sometimes what will happen is they start to develop pain, they start to change their mechanics, they lose some of this strength, you get this increase in neural tension, you start to see a deactivation from the motor side of things from the nerve, and so you start to see them losing strength. So these are things that we can intervene and address. So what does it look like? Well, we said rest from throwing and hitting. Yes, that's important, but we really want to focus on improving those objective deficits. So if we go back to, we remember our numbers, right? We had a shoulder external rotation loss. We had a shoulder strength issue. Once we start to address some of those, and then the timing to allow for that posterior glenoid to start to ossify and begin, then we can start to talk about, okay, what does it look like to start ramping them back up with an interval throwing program and an overall training load? How do we apply appropriate loads across that as we move forward? So when we look at these, we know that there's some throwing related adaptations. So there's these humeral osseous changes that take place, especially when they start throwing at 4, 5, and 6. When they start pitching, you're going to start to see some changes that take place. We think that these are normal adaptations: soft tissue, rotator cuff, labrum, capsule, shoulder and elbow range of motion, and then hip osseous to soft tissue changes. We just feel like that those are some changes that are throwing related that we have to consider, and we have to say and look at them that they may be an asymptomatic, purposeful, adaptive process. And that's what the way Conway describes it. So when we look at older throwers sometimes and they see that they have a labral pathology, it may be adaptive in nature to allow them to get to that point, right? And so in these individuals is a little bit different because they're younger and they're continuing to develop, but there are throwing related adaptations and some purposeful adaptive processes that do take place. So when we look at this, we said throwing mechanics are things that we can affect. We can look at, we can make sure that they're throwing correctly. Well, especially with this little league shoulder stuff, what we see is these high stresses of the shoulder during that late cocking and early acceleration phase. And so what happens, we get this maximal horizontal abduction. And again, think about where the humeral head is it's going back onto the posterior portion of the glenoid. It's externally rotating. We're getting high forces across that posterior glenoid as well. We're getting stresses. But the other piece of it is we get these repeated high forces and torques that are applied to vulnerable tissues, specifically brachial plexus and the nervous system. And so sometimes that leads to this injury. And so we have to address those and make sure that we're actually addressing what's going on from the neural side of things and also the stresses coming across the shoulder. So we think the neurovascular bundle is really, really important, and we have to consider that. So that leads us directly into our treatment sequencing. Now, with all of our throwers, this is kind of our algorithm. We look at them and say, do we need to downregulate their nervous system? Meaning, is their nervous system heightened? Is their sympathetic nervous system on heightened alert, where not only are they getting pain, but they're also getting a motor impairments where their muscles are not activating like they need to? Now, typically what we see is that if it's really high upregulated nervous system, we may have to start with really high level things or low level things like breathing, postural corrections, and cervical and thoracic mobilizations. The majority of the times, what we'll start with is neural mobilizations. because those are, and for this case, that's exactly where we're starting. We've got an increase in neural tension in the median nerve, and so we need to address that to what we would say downregulate the nervous system so that we can then immediately follow up with activation of the rotator cuff, scapular stabilization, activation, and then as well as lower and upper extremity strengthening. So we think the sequencing is really, really important, because what happens is if we start treating a weak muscle on top of a upregulated nervous system, we don't get the full activation of the muscle itself, and so it never really fully takes. So when we look at across the board, what this, if we put them in boxes and kind of decide what is exactly are we focusing on. Now, I want to clarify that this is not time-based necessarily. We're not saying, okay, you're going to go 2 weeks, then you're going to go 3 weeks. It's criterion-based. But with these little league shoulders, we do have to allow a time component, meaning there's certain healing that has to take place. Our job throughout the process is to apply appropriate forces across the tissue to allow them to get stronger, but not to allow them, not forces that are high enough that are going to cause damage or impair some of the ossification that's occurring. So really, we start off and we say weeks 1 to 2, we're just really focusing on motion recovery and a strengthening foundation. Can we downregulate that nervous system and then start to get activation? And then we progress to integrated strength stabilization, pre-return to throwing, then our interval throwing program, and then return to sport performance. And we'll kind of talk through those just briefly. So one of the big things that we look at weeks 1 to 4 is this motion recovery piece. Remember, if we go back to our case study, they're missing a loss of about 10 degrees, about 15 degrees of external rotation, 10 degrees of abduction. So when we look at this, we see this in all of our throwers a lot of times where they have a loss of external rotation, and there's several factors that can contribute to this. One of our go-to things from a sequence standpoint is just neural tension or addressing the neural tension with nerve glides. 90% of the time, if you just look at anecdotally what we see with our throwers, the majority of these individuals that have increased neural tension, it's mostly coming in their median. We'll see some ulnar and radial, but the majority of these individuals we see is coming from the median nerve. So we start off not stretching, but we start off addressing that neural tension to actually see, does that open up our range of motion? The thought and the process behind this is if I have increased neural tension, I'm getting overactivation from the anterior side of things, pec major as an example, or subscap or anything else that's limiting my ability to go into external rotation. I need to decrease that overactivation on the anterior side and then increase the posterior cuff and scapular activation. So we start with sequencing with decreasing the neural tension or downregulating the nervous system. So when we look at that effect of the nervous system, typically we think it's the pain and the symptoms that are coming, and that's one piece of it. It affects the range of motion is another piece, but then the other piece that we really have to think about and make sure we're addressing is that if we have that increase in sympathetic nervous system, then our muscle strength and force production is going to be impaired as well. So we have to address the nervous system prior to actually causing or working on that strengthening and activation. So this is kind of what we start off with, median nerve glides. These are typically when you look at your upper limb neural tension test, these are a little bit different in the throwers because sometimes you have to realize the specificity of throwing is that a lot of these throwers have large amounts of external rotation, horizontal abduction, and then they have cervical side bending with rotation, which is putting that nervous system on a major stretch. And so we have to address and assess in some of those ranges sometimes. It's not your typical upper limb neural tension sometimes. So what we're looking for is we're looking to see, is there increased neural tension? If there is, then let's go through and start gliding and working on addressing that. We will do it manually, but we'll also teach them how to do it. And we're assessing bilaterally, pathological versus non-pathological, meaning does it reproduce my symptoms when I take them into this? Most of these throwers that we see have some type of increase in neural tension based upon the activity that they're performing. Some of it is non-pathological, and we have to discern between those two. We talked about shoulder range of motion. Then in this kid, he was missing about 15 degrees of external rotation on that throwing side. So we're looking to see what is their shoulder range of motion, IR, ER, within the context of humeral torsion. So we're using this dynamic ultrasound to actually assess, looking at the groove to make sure where we're level, what is that range of motion. Again, we won't go into a ton of process about this, but essentially what happens is we're using an inclinometer, we're using the ultrasound to line up the tuberosities, and then we're taking a measurement to see how much twist is occurring within the bone. And then we put that within a context of what their motion loss is. Once we know that, then we know where we need to go to address. Is it a loss of internal? Is it a loss of external? So we're using this, looking at humeral rotational motion within the context of humeral retrotorsion. Once we address, remember with the case study, we said we're missing about 10 degrees of glenohumeral abduction. Well, one of the first things we'll start off with is median nerve glides, looking to see, does that open them back up? In the lower picture, what you see as well is that we will teach them how to do the nerve glides. So tensioners on and off, back and forth, stabilizing with the shoulder. We start off low and then gradually work our way up. And then if we have some type of posterior inferior capsule issues, we can certainly do other stretches, but we address the glenohumeral abduction loss and the modifiable risk factors that we see in this particular case study. Then we said we're missing external rotation, so torsion-corrected external rotation loss. One of the things we'll look at, besides just part of our ER algorithm, besides just the median nerve glides, is we'll look at a pec release. Where the pec major, as it comes across and attaches across the biceps tendon at what we call a zone 2 and 3, where it inserts, they can put compression across that tendon and cause, if that pec major is really tight, it actually minimizes the ability to go into external rotation because of the compression across that zone 2 and 3 in the bicipital groove. And so we'll address that. We'll do a pec release and see, okay, does the motion come back? We'll look at lat to address that. We'll also sometimes go down and we'll look to see, okay, is the subscap tight? Is that what's limiting us? But there's an algorithm that we go through that we typically start off with median nerve glides. Yes, that gains back some of the motion. Then we go to pec release, then lat, and then subscap. So we kind of go through step by step from an algorithm standpoint. I would say the majority of time what we see is we're able to restore that external rotation loss with nerve glides and or pec release. And so those are the big things that really contribute to a lot of this. If there's some really tough ones that's not addressing and restoring all the motion, then we'll go into these other techniques as well. Now, that being said, the sequencing becomes really important here because as soon as we add that new motion, let's say we're missing 15 degrees of external rotation, now we gain that through our interventions, then we immediately need to follow up with posterior cuff and scapular strengthening activation to maintain that new motion. Now, one of the things I want us to talk about is the biomechanical considerations. So if we look at the amount of stress, we talked about throwing and the high stresses that come across the shoulder. When you look at some of these young throwers, we see that the external rotation torque of the humerus is approximately 18 Newton meters in adolescent pitchers. Now, that doesn't mean a lot other than mean the number's pretty large and there's high forces that coming across the overall humerus itself. So these rotational forces across the epiphysis are approximately 400% capacity of the cartilage across the epiphysis. So again, these are high numbers that are coming across the stress of the bone itself and across the cartilage. So from our standpoint, we think it's really important that we're addressing the rotational cuff strength, because if it's not strong enough, and you saw in our throwers, our case study, they were really decreased anywhere from 9 pounds to 14 pounds. So we need to address that from a strength capacity standpoint. So shoulder strength for us is really just a barometer for shoulder and elbow health. If they have decreased rotator cuff strength, scapula strength, it's a good indicator that there's something going on there. Again, we're not saying that's what caused it, but that's a consequence of what's going on. Was it the chicken or the egg? There's something that's going on that we need to address, and that's a modifiable risk factor that we can address. So foundational strengthening 1 through 4 certainly have this postural correction, and then we work on isolated strengthening. These are not anything that is very new or anything that's just extravagant, but it's basic foundational strengthening to making sure that we're addressing. Remember, in this case study, we had loss of scaption strength and an external rotation strength, so we need to address those issues. We have some scapular dyskinesis. We need to address that from a neuromuscular control standpoint. So we just start off with foundational strengthening. This is after the sequencing of restoring that range of motion. We also said that lower extremity function is really important, so we look at balance on the stance and the lead limb. We're in the process now. We've done wide balance for many, many years. We understand what that looks like from the stance and lead limb. We're now in the process of looking at force plates and looking at a vertical power force on their stance and lead limb. So we think that will give us even more information of their ability to transfer force up to their upper extremity. So when we look at this, we think really important. The drive leg and the stride leg are important. Do they have the balance? Do they have the strength? Do they have the power in order to take that vertical ground reaction force and transfer it across? Remember, if they can't do this, and a lot of these young throwers don't have a really good ability to actually transfer force, and so they're throwing a lot with their arm that puts increased stress across that shoulder and specifically across the physis and the glenoid. So going back and just looking at the mechanics, what are they doing when they're on their stance limb, when they go into their setup? What do they do when they hit stride foot contact? Are their mechanics where they need to be? Are they collapsing on the front side? So we're addressing all these issues. And if we do notice different deficits in balance, power, and strength in the lower extremity, we're addressing those things. Again, to minimize the stresses that are on up the chain at the shoulder. Before we go into integrated strength stabilization, we're working on that cuff strength. Remember, we said that rotational cuff strength is really important. We're working on scapular control. We're working on squat to rows. We're working on step to external rotations. We start off in a basic lower level, really working on scapular posterior tipping, retraction, making sure that we're getting them down in a good neutral position down at 0. And then we gradually work our way up to where it's more baseball specific, where we're in a lunging position, when then we go into a single leg position. So we're working on that balance, stance and lead limb, trying to get good integration from the ground up to the shoulder. Now, once we get to the point where we've addressed these issues, we start looking at, are they ready to start beginning their pre-return to throwing? So we're looking for clearance for return to throwing. This is a process that goes through with our physician and with our research and our rehab team, right? And so some of the things that we're looking for is, did they restore their total rotational motion within the context of humeral torsion within 10 degrees of the non-throwing side? We're looking at humeral rotatorsion measurements that we've talked about. We're trying to make sure that we've modified that neural tension so there's little to no reproduction of symptoms. And then we're looking at other things, cervical thoracic spine. We're looking at rotator cuff strength. We're looking at lower extremity balance on their stance and lead limbs. If once we've addressed all these things, then we make a decision as a team to say, okay, you're ready to begin what we call your pre-return or your preparation for return to throwing. So now we go back to that case study. Remember when we started, the very first time, the baseline data, we were missing external rotation. Now, if we start to look at it, we were missing about 15 degrees of external rotation. Now we're about 4 degrees, 4.5, right? So we feel pretty good about that. If we look at glenohumeral abduction, we were missing 10. We're still missing a little bit there, so we want to continue to keep an eye on that. Most of the time that has to do with some increased neural tension that's just not being addressed or not being addressed on a regular basis. And then really one of the important things when we look at this case, if you look at their strength, which was anywhere from 9 pounds up to 14-pound deficits, you see that is kind of normalized. So we see our rotator cuff strength looks better, our scaption strength looks better, and our balance was pretty good the first time. It's even better this time. So what we see is that we've seen some changes. Now, what we don't know is what's going on at the physis and then at the glenoid. So they've met their criteria from a throwing standpoint. So we begin our pre-return to throwing or preparation for return to throwing. The whole objective of this is to prepare these throwers to get back to throwing and experience the forces, the high forces that are coming across shoulder and elbow that they'll experience in their interval throwing program. So we're getting them ready from a plyometric standpoint and we're replicating some of these forces that they'll experience during throwing. So it's typically what we do with these individuals is they're going through anywhere from 2 to 4 weeks of a pre-return to throwing program to prepare them for the interval throwing program. So these are basic things that we start off with that probably all of us use, right? So we start off with rebounder at the chest level, then we start going overhead. We're 2 hands to start with, then we go 1 hand after that, gradually increasing those forces across the shoulder and elbow to prepare them for throwing. Then as we move to the right, what we start seeing is we get into the more rotational forces as well. So now we're doing more baseball specific, more rotational with a heavier med ball and working on power and again, experiencing those forces. Every time I catch that med ball and come back, I'm putting forces as I go into extra rotation. Again, they've met all their criteria from a strength standpoint, balance, neural tension, range of motion standpoint. So because of that, they're ready to go through. Now, as they go through their pre-return to throwing, that 2 to 4 week period, we're maintaining and we're watching and monitoring what's happening with their range. So if we see changes in their range, changes in their strength, or increase in symptoms, then we're backing down. Most of the time, though, we've given it enough time, they've addressed things objectively, we're able to progress through this. Then we're ready for our interval throwing program. Now this is, I apologize, this is kind of hard to see, but we've got an under 15. So this would be those individuals who are 15 or under the age of 15. We've got a different interval throwing program for them compared to what we have for 15 and older. So this is the under 15 program. And like I said, it's hard to see, so I apologize, but it's based upon a training load and kind of across the acute to chronic workload ratio that we're looking at. So what we see in this level 1, so these younger throwers, they'll start at like 30 feet. So there's we're calculating what we call arbitrary units where we've got 30 feet is the distance, right? So that's part of the load. And then they're doing 2 sets of 25 throws at about 50% effort, right? So we're calculating all those together to say, hey, we're giving a certain amount of load on this particular day on level 1 as they start, and then they gradually progress. It's like a weightlifting program. We start off light, we gradually progress over time. What we say about our interval throwing program is that it's not necessarily linear in nature, meaning that you're just going to go straight without any problems. What'll happen is that they'll start off, they start to get to a certain level, they may have a bad day, come back down. So it's kind of a gradual progression as they go up. But we monitor that throughout their program, making sure that their load is adjusted accordingly, and we gradually increase that. And then Natalie, if you'll go to the next, it'll actually bring us to our mound throwing. Once we get to a certain level, then we start going off the mound for our young throwers as well. But the same concept of percent effort based upon number of throws, how hard they're throwing. So we'll start off with just basic pitches to begin with, and then we gradually progress to where we're adding in different types of pitches, which will change the load across the shoulder and elbow too. So finally, when we look at this, we set all of our numbers matched up in this case study. If we go back and look to see what's happening at the bony and the imaging standpoint, again, which we're not necessarily affecting directly, but maybe indirectly with our treatment, if we look at that 12-week follow-up, we start to see some changes that are taking place, not only in the physial widening of the humerus, but also in the posterior glenoid as some ossification is starting to occur. And then by the time we get to that 6-month mark, we really see that physial widening of the humerus start to close. And we see really some good ossifications occurring in that posterior portion of the glenoid at that 6-month follow-up. This is a good example of like, it may take this long, anywhere from 3 to 6 months for this to really start to fill in. But if we can address it early, then once they become 17, 18, 19, maybe we're addressing these issues they don't have in the future. As a perfect example, just last week, we saw 2 Division I baseball players that are both pitchers at a top 20 D1 program that both had posterior glenoid dysplasia and were dealing with and treating conservatively. Now, we don't know, did they have this earlier on, but some of our earlier indications with our data suggest that this may be occurring early on, and maybe it's just missing or is being missed. So from this point then, we've gone through our interval throwing program, we've gradually progressed, we've met all our criteria, we're continuing to monitor that, and then released from medical care for us is a combination between our research team, our orthopedic surgeon, and then our baseball medicine team is our physical therapist. So we're addressing all these issues, trying to make sure, ideally what happens, they get some type of throwing analysis that they go back to make sure that their mechanics are good, or they work with some of our performance team as well. So in summary, traditional care of Little League shoulder may not include the glenoid. We think it's really important, and we think that it's something that needs to be considered. These osseous changes occur at the humeral physis and the glenoid, and that may require this serial radiologic imaging up to 6 months. So it's when you're educating these parents and these individuals, that seems like a long time, but understanding that if we can address this now while they're young, we may save them some further consequences on down the road. And really, the clinical algorithm for evaluation and treatment of Little League shoulder, imaging using the Conway method that Natalie showed, looking at that suprascapular, that curve, comprehensive evaluation of the entire kinetic chain, rest from throwing for certain, but really an active rest. We want to downregulate that nervous system. We want to restore range of motion within the context of humeral retrotorsion, address the cuff strength, neuromuscular control, low extremity balance and power. And then we do have to follow up with the radiographic findings to make sure they're matching up with our treatment. Ideally, what happens is that our patient gets better with the correctable modifiable factors. In addition, at the same time, their bone is starting to heal as well. So we look at this progressive return to throwing, including objective criteria. And I think we have to consider, I think one of the take homes that we want to say is that consider the impact of that posterior glenoid dysplasia on long-term shoulder health. If it's not addressed early, it could flare up again future. So just want to acknowledge we've got a large baseball medicine team. Dr. Conway's on the left here, Natalie. We're very fortunate to have a very strong group of not only researchers, but also physical therapists that work together. And Natalie, there's one more, I think, just to acknowledge some of our, all of our baseball medicine team. So I want to acknowledge them. And Ben, thanks for the opportunity to present this evening. I really enjoyed it and appreciate the opportunity.
Fantastic presentation. And for those who are staying on, please feel free to start typing some of your questions in the chat. I think both presenters would be happy to answer some questions for you guys. Absolutely fantastic. And I'll start it off actually. I noticed, strength measurement is one of the major things. Were you using handheld dynamometer? What sort of measurement tools are you using for the strength measurement?
Sorry, I can't. Can you guys still hear me?
Yeah, we can hear you. Can you hear me?
I'm not hearing anything. Sorry.
Well, I can take it.
Right.
Can you hear me, Ben?
Yeah.
Yeah. Okay. So we do use handheld dynamometry. So we use a microfit that many of you probably have in the clinic. Nothing fancy by any means. I think we are looking to improve that process a little bit. When you have a baseball player sitting on the table that some of them, 180 pounds, brick walls, and I'm performing the strength measure on them, it can be challenging on my end to try to actually truly get an isometric stabilization contraction out of them. So we are investigating other clinically useful methods that we can quickly implement. And there are some options out there that can be hooked on to like weight, what are they called? Like weight racks.
Yeah.
For example,
yeah.
basically they're load cells that can help. And it takes me out of the picture when trying to do something like that. But all the data that we presented today was using a handheld.
And Michael asked what position you're testing them in. Are they in 90-90, shoulder abduction, external rotation? Where are they being measured?
Yeah, so we test them at 0 by their side. I think that's for us. I think Craig potentially talked about that. That's almost like a barometer for us. Can they do it at 0 degrees? Because if they're having trouble at 0 degrees, then it's probably likely that once you get them up to 90, they're going to struggle. And so we got to get them right below shoulder height. And then we can start to implement and raise up into this more 90 functional position and go from there.
Fantastic. And
I think
AB
also
asks,
from
oh, go ahead.
yeah, go ahead. No, go ahead.
I was going to say, AB asks, the glenoid loss that you guys are seeing on the throwing arm, is that from your perspective a congenital thing, a training adaptation, a sign of overuse? What's your hypothesis there?
Yeah, I think it's a combination of throwing while your growth plates are still open. I can't speak on whether it's congenital or not. My gut tells me that this is an adaptive process due to the posterior compressive forces that are happening when you are throwing during a very young age when your growth plates are still trying to close. You're having rotational compression and tension forces happening at the humerus. And then also your subcoracoid ossification of the glenoid at the top and on the posterior, it really doesn't ossify in until you're anywhere between 13 and 16. So on top of you constantly going into extreme layback, repetitive activity, that naturally stresses the posterior side of the glenoid.
Makes sense. And John asks, what about the glenoid labrum? How's that affected, especially the posterior labrum? Would you suspect that there is posterior labrum insufficiency in that situation as well?
Yes, you do see it. And you can see hypertrophic changes sometimes in these individuals that come in later in life. We can't speak to what they look like as a 12-year-old, but we can see as a 22-year-old, they have posterior glenoid dysplasia and they have posterior labral chondral pathology changes that are occurring.
Excellent. And Kevin asks, in a symptomatic little league shoulder, would you advise them to continue participating in asymptomatic fielding positions, refrain from return to pitching, of course, until you see posterior glenoid ossification?
It's really hard for a 12-year-old to refrain from doing anything on the field unless you kind of pull them out of that. And so our philosophy is educate them, show them the images with the orthopedic surgeon, talk to them about what they're seeing, and pull them out and let them concentrate on their physical therapy, let them concentrate on the deficits that we talked about, that Craig talked about in the presentation, whatever they may be. And it does stink and it takes time, but 95% of the time when you educate them and you actually show them what you're looking at when it comes to not only the proximal facial changes, but specifically the glenoid rim, they see it. You can't really unsee that, right? It's pretty prevalent. And so I would say pull them from activity because it's going to be really hard for them not to pick up a baseball and throw it.
Makes sense. Jordan asks, are you guys noticing any consistent physical exam findings that are pre-existing conditions or contributing factors prior to seeing this condition develop?
Let's see. I'm trying to think back. Pre-existing conditions. Off the top of my head, I don't know. No, that doesn't mean that they don't exist, that I'm not seeing them from a systematic. So I'm not sure on that one. And
yeah, Ben,
Craig, I don't know. Craig, there you are. I can't think of any.
I don't know what happened to my. Yeah, sorry, I don't know what happened to my speakers. I will say I agree with Natalie. I'm not sure that we know any pre-existing. One of the interesting findings, and again, this is about Little League shoulder, but we've started looking at this in our Little League elbows as well. So for instance, they come in with elbow pain, and we'll take these x-rays of the glenoid and we see the exact same thing, right? So, and their shoulder's not hurting at all. So there's something going on with these young throwers, and it really just depends when you look at the load sharing between the shoulder and the elbow, which gives first, but we're still seeing the changes that are taking place at the glenoid.
Interesting. Yeah, I wonder if a asymptomatic x-ray series in a otherwise healthy population might show similar things.
Yep.
So Josh asks, is there a specific age you see these injuries more commonly in? He assumes just general adolescence. Has that been your experience as well?
The pediatric side of things, where the growth plates are still at risk, is where we're kind of seeing this. However, like Craig said, and I made a comment earlier in the Q&A, what happens when it goes unresolved from when you are continuing to pitch later on in life? Because a lot of these college kids, even late high school, where growth plates are already closed, they're coming in with shoulder pain. They might not have the drasticity of it in terms of like that angular delta, but there is some type of dysplasia that is occurring in those individuals. So, and we don't necessarily know. I've started asking individuals just because I think it would be really interesting as a baseline if they've ever been diagnosed with little league shoulder for anything that they come in with, or little league elbow, so we can kind of try to start to correlate some of these things. But right now it's mostly pediatric, but it does carry over, and we can see it in the later adults.
Oh. Claire asks, in the absence of force plates to compare vertical ground reaction force, what tests of unilateral lower extremity power are you selecting to evaluate your athletes?
Claire, great question. Yeah, there's certainly limited with that, right? So there's certain things that you can do. You can get them on a shuttle type thing to actually test their power. It doesn't necessarily give you an objective number, but it gives you some ideas of what they can actually do from a force production. And then just simple, even without force plates, you can measure. There's certain kind of wearable technology that you can use to assess vertical height. So how much, and that's kind of an indirect measure of how much power can they produce on their stance versus their lead limb. And so when we look at it, we really think, if I'm looking at a right-handed thrower, I need to assess the stance limb, being able to exert vertical ground reaction force, right? So how much power can I produce? But then on the lead limb, they need to be able to produce, they need to decelerate that force. So as they go forward with their lead limb, they almost go into a lunge type position. So they need to be able to decelerate that, get the vertical ground reaction force, and then rapidly transfer it. So you could, on the lead limb, you could have them just doing lunges to see what their overall ability for power is as well.
As a follow-up, then, I think, Claire, back when my roots was in tennis medicine research, and we would do a time in air jump height, and some of the tennis medicine stuff that I did, that was showing to be a pretty good indicator of, I wasn't able to correlate it to injury before I left my time at Kentucky, but from a performance standpoint, it seemed to correlate with higher performance, and that was just a single leg or a double leg jump, right? Vertical jump. You might have a vertec even. So there are ways that you can get creative in clinic to try to give you an idea if you don't have a force plate.
We'll just do a couple more questions just because I know we're way over time, and I want to respect you guys and your time as well. Catherine brings up a great point for the many states now that have direct access. If they suspect little league shoulder, is the imaging angle that you guys suggested common enough knowledge that we can refer out for that specific type of imaging to a orthopedic or a sports med doc?
Yeah, I think that's a good question. My answer would be, and Natalie, you can follow up on this. My answer would be no. The majority of orthopedic surgeons are not looking at this. As an example, we've fought a pretty strong battle with our imaging group to make sure that Conway can get the measurements that he wants. to the point where Natalie and I have been into X-ray with Conway, with the X-ray techs, and him positioning the athlete. So I would say there are some individuals, some of his colleagues across the country that take care of some big time baseball teams across the country as well that are starting to buy into it, but it's not common across the country at this point in time.
Fantastic. All right. And the last question from the group was, are we getting this PowerPoint or the recording? Yes, I will send out both. And as I suggested, we've got a number of great topics coming up in 2025 as well. And real quick, Craig, do you want to mention your research symposium?
Yes, thanks, Ben. So one of the things that we've been doing in Texas over the last 10 years, we started off with a small group of sports and orthopedic residencies about 10 years ago, started looking, and we all started getting together, and it's a platform that allows residents to present their research. This has grown over the last 10 years, and so to the point this year, we are opening up to a national audience, and so we're starting to kind of advertise that right now. I sent Ben a save the date flyer in April, end of April next year. We will have our 11th annual Texas Residency Symposium, and so we invite anyone who's interested to attend.
All right. With that, we will close the show. Really, really appreciate our amazing presenters for this really cutting edge information. Very exciting to see it. Thank you for all you guys who came to attend tonight, and look forward to seeing you at the next one.
Thanks, Ben. Thanks, everyone.